Hello, good evening. Hi, welcome everybody. It is 7 p.m. So if it's okay with you, we're going to go ahead and get started. All right. So good evening and welcome to the League of Women Voters webinar, Crisis Intervention in Montgomery County. Is calling the police always the best idea? I'm Leah White and I'm the moderator for this evening. So thank you for joining us. When crises arise, a number of us do what is most familiar, call the police, rather than do what is most effective, which is to mobilize resources of specialized expertise in this area. Yet the traditional approach may be detrimental to many, especially for those with drug use or mental health concerns. What is Montgomery County doing to solve this problem? Tonight's panelists are well positioned to address this question and to take questions from you, the audience, following the presentation. But before I introduce the panelists and turn the meeting over to them, let's review a little housekeeping details and some rules for tonight. This evening will be recorded and live streamed. The video recording will be available the next day or so on our YouTube channel. The web address will be available in the chat box to everyone. After our speakers give their presentations, we will provide a question and answer session. We encourage you to ask questions. Click on the Q&A button at the bottom of your screen, type your questions into the box, and then hit send, enter, or return. And we will answer as many of the questions as time allows. The program is scheduled to end at 8:30 p.m. Now, if you give me a moment, I'd like to introduce tonight's speakers. First, we have Carrie Guthrie Cho, a president and CEO of Cornerstone Montgomery, the largest provider of mental health services in Montgomery County, serving over 2,400 people since 2012. She's a licensed social worker who's been working in community mental health for over 25 years. She earned a master's degree in social work from the University of Maryland. Ms. Cho is actively involved in implementing evidence-based principles, including non-crisis intervention, and facilitates related training and consulting throughout Maryland and DC. She serves on the board of directors for Community Behavioral Mental Health Association of Maryland and on the National Council for Mental Health Wellbeing. All right, and our next presenter is Dr. Orlando Santiago, the Chief of Behavioral Health and Crisis Services from the Montgomery County Department of Health and Human Services, a job he began in October 2020. As a chief, he has oversight of mental health, substance abuse, addiction, and crisis stabilization services throughout all of Montgomery County of residences of all ages. Dr. Santiago has over 15 years of experiences in mental health services, intellectual and developmental disabilities, health equity and cultural competence, and the program evaluation and system changes. He earned his doctorate from the State University of New York in Albany and is a lecturer at the Johns Hopkins University of Bloomberg School of Public Health. Join me in welcoming Dr. Santiago. And our next presenter as well is Bernice Miracu North, who is a co-chair of Montgomery County's 2021 Reimagining Public Safety Task Force. She's practiced law first as a prosecutor and then as a criminal defense attorney over the past 7 years. She is a graduate of Howard University School of Law and a past member of the Inn of Courts of Montgomery County, Maryland, an association of law professionals who meet to discuss issues around skills, ethics, and professionalism. She's a member of the Montgomery County, the Maryland Attorney Grievance Commission. Let me repeat that. I'm sorry so much. Let me repeat that statement. She's a member of the Maryland Attorney Grievance Commission and informed chair of the Silver Spring Citizen Advisory Board and a former member of the Judicial Inquiry Board. And so I hope that you will join me tonight in welcoming Ms. Miracu North in beginning tonight's presentation. So thank you everyone for joining. Ms. Miracu North.
Thank you. I hope everyone's having a good evening, and thank you to the League of Women Voters for the opportunity to engage in this conversation. As mentioned, I served as co-chair of the Reimagining Public Safety Task Force, and my contribution to the conversation tonight essentially is to provide a summary of the recommendations that squarely fit into this subject. So I'm just going to show a quick PowerPoint to provide some context into that. Yes, so as I mentioned, this Reimagining Public Safety Task Force, something that I co-chaired along with Mark Maurer, and there's approximately 45 community residents and several other stakeholders in the group. And I'm saying that to kind of give you some context as to the breadth of involvement in this particular task force that led to these recommendations. In addition to myself and Mark Maurer as co-chairs, we had 5 focus group areas, and I'll explain a little more about that in the next slide, but they each had co-chairs, and then there were community members involved. We also had the representatives of Montgomery County, mostly county agency representatives that were really there to provide information, because essentially these recommendations were coming from the community members themselves. And the representatives from Montgomery County really just provided some resources and insight into our process in developing these recommendations. In addition to what I just mentioned, we also had public input as well. We had a couple community forums, as well as we spoke to different organizations across the county to get some insight into this matter. We also had a consulting group, Effective Law Enforcement Change for All, that helped shepherd our conversations to produce this report. And they have had experience across the country in dealing with the question of how to reimagine public safety. So we had a very thorough group, well organized and very passionate about these issues. And mental health was definitely an overarching theme in our conversations. In fact, one of the mantras of our group was to deal with how can we respond to crises involving health or social services where police fill the void. And so among these 5 focus areas that you see here, focus areas 4 and 5 dealt with that question the most. The other ones definitely played a part in the conversation, but talking about alternatives to jail, best practices for crisis response to social services, their groups really dominated the recommendations that we were able to provide to the county executive. So as I mentioned, there were several organizations regarding the mental health response, and 10 out of our 87 recommendations addressed that. As I mentioned earlier, it was mostly dominated by the four and 5 focus groups. So I'm going to quickly go through the recommendations because honestly, Dr. Santiago and Ms. Cho will actually supplement a lot of the reasons why we recommended these initiatives for the county executive to consider as he worked on his budgets for this cycle and for cycles to come. So the main recommendation to start off with is that we wanted to have an established countywide organization with oversight over the ecosystem response. We really thought it was important that of all the organizations and entities in this county, they should be working together, and there should be one agency or at least one person kind of overseeing the development of this ecosystem and its sustainability and its effectiveness. So we were asking for that particular recommendation. Recommendation 40 dealt with a systematic process of universal screening to do the least harm. So we're not talking at the point where, they're already in the criminal justice system and, they're about to take a guilty plea. We're talking about at the very beginning of the stages of the crisis, whether it's on the streets or whether it somehow ends up in the courtroom. There needs to be a universal screen to determine what the needs are for individuals. And it doesn't just start and stop with people who have mental disorders affirmed by a doctor, but people that might have issues with housing or food insecurities, anything that might enhance the negative impact on one's mental health. And those are some of the things we wanted to see happen at this screening level. Recommendations 80 and 87 dealt with implementing the Crisis Now intervention model, which I know Dr. Santiago will get into a little bit later tonight. But we supported that model here in Montgomery County, and not just the fact that we support it, but we have certain criteria that we really wanted to see happen at a minimum when we have this model. And there's several of them. If you go to, if you Google RPS Montgomery County, you'll see the link to our task force work in the report. So I don't want to bore you with the long list of recommendations, but essentially it dealt with, at a minimum, we have to be cognizant of the diversity of this county. So we have to be culturally competent when we are implementing the crisis model, as well as providing the fact that we need to be sure that we are open to all referrals. No one's turned away, because as is mentioned here, crisis care for everyone, everywhere, every time, as well as having peer workers as well in the crisis model format. The next one is, and forgive me because I have the way I have my grid, it's hard for me to see. Okay. Expand the number of mobile response teams to support the implementation of Crisis Now. And I know there's, I think the police additional 4 team members, I believe, that has that's going to be forthcoming in the county if it hasn't already been paid for, or those people haven't already been hired. I know that's in the works as well. So that's another recommendation that we were seeking for the county. Recommendation 84, implementing the CAHOOTS community response model, which is different from Crisis Now model. Crisis Now model deals with crisis intervention. CAHOOTS model deals with community response that can be better served without using law enforcement. So when one calls 911 for a particular crisis, who's going to show up and address the problem to take them to the appropriate services that can be done through the Crisis Now model. So that's one thing that we were stressing as well. And I know that's something that has been in the works in the county as well to try to implement. Recommendation 82 dealt with crisis and, dealt with development and implementation of the Stabilization Center. Again, that's part of the core model of Crisis Now that I know Dr. Santiago will touch on later tonight. We also wanted to make sure that these centers and facilities were staffed with peer workers. A lot of the discussions in our focus groups and the task force dealt with learning the effectiveness of peer workers, and we felt that that was very important, especially, again, given how diverse this county is, with a variety of backgrounds, understandings of mental health. Having peer-to-peer workers, we felt was the most effective way to have a successful model in the county. The recommendation about training the recruits, that really stemmed from the fact that currently about 60% of the current police force is trained in crisis intervention training, but we were seeking that all new recruits receive that training before graduation from the academy. And last, we dealt with the fact that, again, I touched on this a little bit earlier tonight, but developing and implementing a coordinated and integrated wraparound services. And again, that goes to the ecosystem mindset, making sure that all the agencies that we have a lot of great nonprofits and agencies, you're hearing from 2 of them tonight, but finding a way to have it very clear how everyone works together to address the mental health responses that could really, save a lot of lives, and again, deal with not criminalizing mental health in a way that they could be doing more harm to the individuals involved and their families and the community. So those are some of the recommendations that we had. Like I said, those are 10, but those are the recommendations that we had provided. And that's something that we hope could be implemented. It hasn't already been implemented this year, in the next few years. That is our desire. So with that, I conclude the presentation.
Well, thank you very much, Mira Kunor. I would now like to invite Dr. Santiago to give us his presentation.
Good evening, everyone. I'm also would like to thank the League of Women Voters for this exceptional event where we're discussing issues on how to respond to people that are experiencing behavioral health, a substance use crisis. So I appreciate very much this initiative. and also the opportunity to speak with you with my two colleagues, Bernice Mirago North and Carrie Guthrie Cho. So I think we're going to place our my PowerPoint. So we're on our way to implementing the Crisis Now model in Montgomery County, Maryland. Next. So when we speak about the Crisis Now model, what are we really talking about? First of all, it is a behavioral health response to people experiencing a behavioral health crisis. That's our goal, to provide this type of response as an alternative to both a law enforcement response as well as a response by a medic, for example, from fire and rescue services. This model includes an integrated call center. It includes mobile crisis and outreach teams. It includes a stabilization center, and it includes also the crisis care follow-up. And all of these elements were discussed in the recommendations that we just heard from Bernice. So there are several very important goals that I want to bring everyone's attention to with respect to the implementation of a Crisis Now model. The goals are first to divert people that are experiencing a behavioral health crisis from landing in jail, being incarcerated, or in a hospital emergency room. There are other best practices for people experiencing a behavioral health, a substance use crisis that do not require us to deploy these current responses that we have, an emergency response, an emergency room response, or incarceration. But as Bernice discussed previously, we want to respond equitably. What that means is that every community gets a chance to feel safe, and that the response that we're providing is culturally appropriate to the community to which their members in crisis belong. And as you know, Montgomery County is one of the most diverse counties in the country. I think I've even seen statistics and reports that indicate that we're in the top 10 jurisdictions with a million or more people that are highly diverse. We have many immigrant communities in this county. We have a large Latinx community, a large Black community, a large Asian community, and many, many other groups from different national origins. But it's also important that not only do we respond to individual members of those communities, but we are actually engaging those communities directly so that the responses that we provide are responses where they feel like we're intervening appropriately, but that we're also intervening in ways that makes them feel safe. Not only the individual who is in crisis, but also family members and the community at large. There are some essential features of a Crisis Now model that incorporates also the best practices of the CAHOOTS model from Eugene, Oregon, that was discussed in the previous presentation, and also the Asante model. And those are that we respond, that the response in the crisis now model is an independent civilian first response without police. And it also uses peers as first responders. Who is a peer? A peer is someone who may have had a substance use issue in the past and is able to identify closely with a person's experiencing, let's say, an overdose. Or it's a person who has experienced suicide ideations in the past and has volunteered or is working within this model to also identify with persons that may be experiencing the same condition. So let's talk about that first element, call center integration. And what that means is that usually when there is a crisis, someone makes a call. Now, who are they going to call? Typically, it's 911. 911 has its protocol, and it does have a behavioral health protocol as well. And then the dispatchers sort the calls and decide who's the most appropriate, what's the most appropriate response. If it's a crisis center where we have mobile crisis units, they will call the crisis center and deploy or dispatch a mobile crisis team from the 24/7 team that has existed here in the county since 2009. So that's how it works. People who call the 911, or maybe they may call directly the crisis center hotline, or they might call the suicide prevention hotline that Every Mind runs here in the county. Some may even call 311. But whatever way you call, the ideal is that the dispatcher in those call centers will use the same protocol and will alert the appropriate entity to respond to someone in crisis. So what we want to do is to integrate, make sure that all these different call centers are using the same protocol, and we're putting some efforts to ensuring that happens. And I will be mentioning that next, what will happen in the next 12 months. One of the activities that we will be doing is engaging with a Whitebird Clinic, which runs the Cahoots model in Eugene, Oregon. And they are experts. They've been doing this work for 30 plus years. They understand how the protocol works, how the 911 dispatchers call the Whitebird Clinic and engage the Cahoots team. And so we will be receiving technical assistance from them, from experienced persons. Not that we already have experience. I mentioned that we have had at the Crisis Center 24/7 mobile crisis unit since 2009. What is most important is that we're moving in the direction of having, of being able and of responding without a police escort. Currently, most of the calls, if not all of the calls that come to the crisis center, engage a mobile crisis outreach team that consists of a therapist and of two therapists, and they deploy, but there's always a presence, a police presence. We are engaging the Whitebird Clinic, who runs a Cahoots model, to ensure that all of our therapists, everyone working, including peer support specialists, who will also join these teams in the near future, that they're also feeling safe in certain situations, that they're able to respond without a police escort in certain situations. And as I mentioned before, we're in process of developing a common triage protocol, and that's with all the entities that I mentioned already, and primarily or especially with fire and rescue and with a police department. So we want to ensure that we have a coordinated and that everyone understands how the mobile crisis and outreach teams will respond without a police escort. The next slide. In this slide, we're discussing the second element of a crisis now model, which is having mobile crisis and outreach teams. And those words are very important in this slide, mobile crisis and outreach teams. And the reason I say that is because the current response and the current capacity that we have in Montgomery County goes beyond just a mobile crisis team. It also we also have in this county community outreach teams that also respond in certain situations, perhaps not necessarily all of them persons in crisis, but they do respond with homeless populations or with other persons that may require the outreach work. And I will be a little more specific about what I mean by all of this. First of all, with respect to the mobile crisis and outreach teams at the crisis center, which is located at 1301 Picard Drive, we are expanding them. We got funded last summer to hire 6 new therapists. They were funded by the council. And with those, we have hired 4 of them, and we're getting close to hiring all 6 of these members. And once we have these 6 members, we will be able to deploy, instead of just 1 team, have 3 teams available. And actually, already we have 4 of those therapists working for us, and we've been able, in certain situations and certain evenings of the week, to deploy 2 teams rather than just 1. So already, even before we have the 6 therapists in place, we're already deploying 2 teams, but we expect to deploy 3. We also have, I mentioned that we have many outreach teams as well. Many of them are run by Services to End and Prevent Homelessness. We commonly know Services to End and Prevent Homelessness as SEF. SEF has 1 full-time equivalent outreach coordinator that oversees the strategy, the outreach strategy. And just to give you examples of the different groups that are reaching out, especially to homeless populations, we have Pathways to Housing DC, we have Bethesda Cares, we have Every Mind, we have the City of Gaithersburg. We have also Pathways to Housing through a grant from the federal government through the Substance Abuse and Mental Health Services Administration. And we have also a group called Healthcare for the Homeless that also provides outreach, community outreach teams. The police department has the Community Intervention Team, CIT. We have 1 therapist that is from the crisis center who is embedded within the crisis intervention teams of the police department. And they have 2 officers who are fully trained in behavioral health response. And this therapist works very, very closely with them when the police department is responding to certain behavioral health crises. The Fire and Rescue Services also has 1 full-time social worker and 2 mobile integrated health paramedics. What that means is that these are paramedics that have specialized training in behavioral health. Let's go to the next element of the crisis now model. Well, before I go to the next element, let me just tell you what we're planning to do in the next 12 months with the mobile crisis and outreach teams. The county executive in his budget for fiscal year 22 has proposed to the council, and the council is right now in the midst of considering and approving the budget. But it appears that we will have 4 peer support specialists that are going to be funded through the fiscal year 22 budget, and 2 additional therapists. And that's going to allow the crisis center to increase the mobile crisis and outreach teams from 3 that I mentioned before to 6 next year. So we're looking forwards to expanding to 6. This expansion of teams means that we're not only going to deploy the teams from the Picard Drive location, but also from other locations across the county. And the next 2 locations that we're targeting are the Silver Spring area and the Germantown areas. And right now we're in conversations for locating space for 2 teams to deploy in those areas. And we also have proposed to the federal government and have submitted a grant application for another grant that would allow us to even go further and hire 6 additional peer support specialists. We have a dream that possibly we might be able to expand next year from 6 to 8 if we do get the SAMHSA grant. There's also training and technical assistance from the Whitebird Clinic that I mentioned before. We're going to provide this, and it should happen within the next few weeks. And this training is not only for staff within the Department of Health and Human Services where I work, at the Crisis Center, but also Fire and Rescue Services, and also the Police Department. But beyond these entities, we're going to offer training to community groups. So if you're aware of community groups that would like to have their members participate in, especially in de-escalation and community engagement and community outreach training, we would like to know. Send us their names, their email addresses, so they can be contacted to participate in this training. And they're also going, Whitebird Clinic is also going to do some additional specialized training amongst our partners, Fire and Rescue, the Police Department, and also within the mobile crisis and outreach teams in the Department of Health and Human Services. At the Crisis Center, the mobile crisis teams also will be incorporating peer support specialists, as I mentioned before. And that's going to be another step we're taking, as well as what I mentioned before, respond in some crisis situations without a police presence. Next slide. The next element of the Crisis Now model is having a stabilization center, and we're working on this as well. So right now, we are working with the Department of General Services within the Montgomery County government, and also with the Department of Health and Human Services and the Department of Corrections and Rehabilitation Center to complete a program of requirements. It's basically a proposal for a stabilization center that will be located in the 7 Locks area where there is a detention center. It will be a brand new building there. What will happen in the next 12 months? We expect to have the proposal incorporated into the capital improvement program. It's called a CIP, so we can continue to move forward with the plans to build the stabilization center. We also are looking, will be looking for an operations partner from the private sector who will operate the facility. So this will be a public-private partnership. And but at the same time, we can't wait 3, 4, 5 years before this building is built. So we're already exploring, possibly with additional funding from the federal government, to open an interim stabilization center, probably at a smaller scale than the one at Seven Locks. And we're also working with a behavioral health work group that is sponsored by Nexus Montgomery, which is a collaborative amongst the hospitals, to also have them possibly develop an interim stabilization center. The stabilization center is very, very important because this is the alternative to incarceration and to an emergency room. Rather than sending individuals to a jail or to an emergency room, this stabilization center has the capacity for short-term, 24 hours, 48 hours, 72-hour stabilization of an individual who has had an overdose or has experienced a traumatic event of self-harm, or has acted up and requires stabilization. And then that leads me to the fourth component of the Crisis Now model, which is what we refer to as a crisis care follow-up. And this is an area that my colleague Carrie Guthrie-Cho is excellent at, has a tremendous amount of experience over the years, and in a few minutes she'll be discussing that. So what do we mean by crisis care follow-up? Once individuals are stabilized, then they need either a higher level of care or possibly a lower level of care. People in crisis are their response to a crisis is very different. Some may need intensive follow-up, and others may be able to go home. So the crisis care follow-up ensures that persons in the end land safely in what I call a safe service environment. The Crisis Now model uses the metaphor of an air traffic control. Air traffic control's responsibility is to guide an airplane from the time that it leaves an airport to the time it's flying in turbulent winds in the skies, to the time that it lands safely. And we know that 99.9% of the time airplanes land safely. That's what we aspire to do with people with a behavioral health crisis. We want to land them safely in a safe service environment. So what are we exploring with respect to this over the next 12 months? Right now, I'm in conversations, especially internally within the Department of Health and Human Services, in a possible pilot where we're developing a database of resources in the community that does not just include the services provided by the county, but also the whole network of nonprofit providers in the community. So there's a platform called Unitas, and our dream is to be able to be incorporated into Unitas and be able then to access all the referral sources for people who are in crisis. We're also talking about positions that we call navigators, who can walk, accompany, make sure that each of the individuals who are in crisis has someone that is watching over them and makes sure that they land safely in a safe service environment. Next slide. And this is my concluding remarks. I feel there is a growing spirit of enthusiasm and collaboration across partners to implement the Crisis Now model in Montgomery County so that people who experience a behavioral health crisis have alternatives to emergency room admissions and incarceration. I'm very, very grateful to those partners. I'm very grateful to the network of providers in this county. And I look forward to the time when the Crisis Now model is fully implemented to the benefit of all of our communities here in Montgomery County. Thank you.
Thank you, Dr. Santiago. And finally, I would like to invite Ms. Cho to share her presentation.
Yes, now I'm unmuted, so I guess I'll start over again. I'm Carrie Guthrie Cho. I'm President and CEO of Cornerstone Montgomery, and I'm very happy to be here tonight. I want to thank the League of Women Voters for sponsoring this great event, and I'm very honored to be part of this panel. I'm going to also share my screen and share the slideshow. Okay. So really, I want to kind of highlight some of this has been talked about already, but just kind of touch on what are some of the crisis services that we have in Montgomery County. And this is probably not an exhaustive list, but these are the ones that most people probably know about. So obviously, if there is a crisis, people often call 911 first. And sometimes that is appropriate, but as we heard at the beginning of this discussion, sometimes maybe that isn't so appropriate. And part of this whole process is to try and divert people away from jails and hospitals who really could be better served by getting actual treatment and care in the community. The next line of defense might be considered the crisis center. We have a long-standing crisis center in this county who does everything from supporting accident victims with the police on the major highways to having a mobile treatment services that we've talked about, to having walk-in support and a hotline. So we're very lucky in this county to have such a service provider, and we obviously work very closely with them. There also are the hotlines that are mentioned. We have a variety. There's the national hotlines, we have a state hotline, we have local county hotlines for various things, usually crisis and suicide support. Those things are also available to people. Then there's also something called residential crisis services, which people don't always know about this. But this is something that is an alternative to an inpatient psychiatric hospitalization, or it could be a step down from a psychiatric hospitalization. If you're in the hospital, you're doing better, but you're not quite ready to go home yet, you could step down to what's called residential crisis services. Cornerstone Montgomery has 24 beds. We have 3 houses in the community that provide these services. There's another program called Safe Journeys that also has a house in the county. And even the Crisis Center has, I believe, 4 beds that also provide these services. So we have this resource as well in the county. Also, there are something called assertive community treatment teams. These are programs that help people who tend to struggle with your traditional treatment models. These are the folks who are often in and out of the hospital, in and out of the jails, often homeless, and are not someone who does well with, say, going to appointments every week at a clinic. They are going to be out on the streets, they're going to be out in the community, and they need a team of professionals who's going to go to them and find them in the community. And this team has all of the providers on it that you could imagine. They have psychiatrists, nurse practitioners, nurses, therapists, supported employment specialists, substance use counselors, and peer specialists, all on one team that kind of go to wherever the client is. And there are a couple of providers of ACT services in the county as well, including PEP and Cornerstone Montgomery. So these are other options for people who might be in crisis or tend to struggle with traditional treatment. And then, of course, hospitals and emergency rooms. Unfortunately, we have many clients who, when they are not doing well, their first thought is to go to the emergency room. And that, again, always isn't the best option. Do they really need to go to the hospital? Do they need to be in the emergency room? Could they go to an urgent care facility? Could they go to a residential crisis bed instead? And so these are the resources that are out there that we're trying to enhance and improve with all of this discussion and the task force. And I think that's a very good thing. The other thing, I saw that there was a question about mental health court and what our experience at Cornerstone Montgomery has been with the mental health court. And I'll say that we are one of the providers for people who are in mental health court. Mental health court is a court where people might be accused of a crime, and instead of going to jail, they can work with the judge to be sentenced, for lack of a better word, to community support, community treatment, instead of going to jail. So we would be that alternative for some people, and we do work very closely with the mental health court, and it has been a very positive experience for the most part. There are definitely challenges with just issues and accessing services sometimes and different things, but it has been a very positive experience for us, and we're happy to be a part of that and to partner with the mental health court in the county. So what are the challenges of these services? I think when I spoke of all of those services, there are definitely positives that we have so many of these services, that we have so many providers. The nonprofit partners that Dr. Santiago mentioned are key. All the hospitals, the police department, fire and emergency department, those are all key partners in this process. But there are definitely some challenges. And these are just, again, some of them. These are the ones that I hear about all the time as a provider in the community. The awareness of resources. People just don't know what's out there. Most people have never heard of residential crisis services, for example. And how do we get that information out to people? So Dr. Santiago mentioned that part of this model is looking at building a database, something maybe called Unite Us that could help with that. Having people that are really aware of those services and can refer people. Where can they find these community resources? So I definitely see that as a need, that people just aren't aware of what's out there. So we need a one-stop shop, one place where they can go and have people who can navigate and get them that information. I think access to resources, and this is about both capacity with beds and capacity with hours and coverage. So for example, hospital beds, inpatient psychiatric hospital beds have been decreasing over the years. And now you hear the horror stories of people being stuck in an emergency room for days, not just hours, but days, while the emergency room staff try and find them a bed anywhere in the state, or even DC or Virginia or Pennsylvania. So that is a problem. That is obviously a capacity issue and something that needs to be addressed, but it is a challenge because obviously it costs money to open beds. So that is definitely a challenge and an issue. Even with our services, residential crisis beds can sometimes be hard to come by. We might be full, we might not have any beds available, or there are barriers such as insurance. I believe that Cornerstone Montgomery is the only residential crisis provider that accepts private insurance right now. And so that's a key aspect. We're open to some of the private insurance where many others are not. And so that's, I think, a challenge as well and a barrier for some of the access to services. Also, they mentioned mobile treatment, the mobile treatment and the response teams. There is one, I think, that is available 24/7, but historically they haven't always been available 24/7. So sometimes you would call, but they were closed, or sometimes you would call and they were already out on another call, so they couldn't come and help you, and you had to find other resources. So I think what they've talked about is trying to improve that access and having multiple teams so that they can deal with multiple situations at once, which I think is definitely a need that we've seen in terms of capacity. There's also just the ability to divert from jail or from even hospitals or emergency rooms to other providers. A lot of times police and fire or paramedics don't have alternatives. They don't know what they are, or there are barriers to accessing those alternatives. We have a great relationship with hospitals, and inpatient psychiatric units will be happy to refer to our residential crisis program, but emergency room doctors, they're concerned. They're worried about saying to someone who comes into the emergency room in a crisis, well, instead of accepting you here, why don't you go to this residential crisis bed? And they have concerns about that. So trying to understand those concerns and work through that process and developing better partnerships so that emergency room physicians feel comfortable making those diversion referrals as well. So that's, definitely an issue that we see. The last one is, it is a bit of a controversial issue, but I just want to bring it up because it's being talked about now at the state level and around the country. But most states have a much broader definition of what determines if someone is a harm to themselves or others than Maryland does. Maryland has a very limited definition, and this sometimes makes it a barrier for people to get treatment when they are decompensating and are having a psychiatric crisis. Many other states include terms such as increase in psychosis or an inability to take care of, activities of daily living. So this would include someone who is no longer bathing, no longer eating, really struggling to do some basic daily activities that really could end up becoming a harm to themselves. Other states are a little more flexible in recognizing that those might be a reason that someone might need to go into the hospital. Maryland has not made that change, although they are looking at it at the state level. But I do think that this does present a barrier sometimes for people who might need to be hospitalized and get more intensive treatment on a temporary basis, but are not able to do so because police or the judges or even the doctors at the hospital can't say, well, this meets the legal definition in the state of Maryland. So that is another barrier that we've seen, but the state is currently looking at that definition. So how will the next steps help? Well, I think the things that Dr. Santiago shared that are part of this model and that the task force also recommended definitely could make a difference. A call center would certainly streamline triage, having one point of entry and then appropriate referral out. They'll need lots of training for the staff. Those navigators that were mentioned need to know what's out there. They need to know where to find that information because obviously having resources is one thing, but knowing where to refer people is a total, different matter. So we'll need to make sure that people are really aware of what's out there. We also need to make sure there's capacity in the community. A lot of times money is put towards crisis services, but then what? Where does the person go after that? We have to make sure there's capacity for when people aren't in crisis, not only because they need follow-up after the crisis, but if we can get some support before the crisis happens, maybe we can prevent those crises. So making sure that there is capacity in the community, that there are enough community providers, that there are enough community treatment options, that just needs to be an ongoing discussion that we need to have as part of this conversation. The mobile treatment expansion, I think it's definitely helpful. And as I already mentioned, if it can be 24/7 around the clock and then having multiple teams, which is definitely sounds like that's what the plan is, that can actually really have a difference and have an impact on the support when someone's in crisis. Stabilization center, that's really going to help coordinate care and have, these are actually popping up all over the country and definitely are having an impact on people's lives. It could be part of a federal model. There's something called CCBHCs, Certified Community Behavioral Health Centers, that can incorporate services like a stabilization center into the funding, which is federal and Medicaid funding with some state matching. And Maryland is showing some interest in CCBHCs. There are actually 4 CCHB providers in the state. Cornerstone Montgomery is one of them. And there's a lot of different ways that CCBHC, that model, it has federal structure, federal standards, and can really expand on a lot of these services that we're talking about tonight. So it's great that the county and the state are really being proactive and looking at how they can make changes and expand what we're already doing. I think the use of peer counselors is key. Hopefully we can move forward in Maryland and have, peer counselor and peer specialists be approved as Medicaid providers and a Medicaid service. That's something that's been in process for a while, but hasn't happened yet. So that would be very helpful for those of us who are Medicaid providers. It's another way to pay for that service. But I know also, we've also gotten grants to hire peer counselors as the county is trying to do. And that is definitely an asset to any treatment provider, any program. The CIT training for police officers, any training is key. Any training is going to be helpful to identify that support and make sure people understand what the needs are. And the follow-up, as I mentioned, I think what's key about all of this is identifying and filling in any gaps in resources so that people have a place to be referred to for support, whether it's before, during, or after a crisis. And before is key because that can be prevention, which is always the definite best option. So I do think that all of these conversations have been very helpful. There's going to be ongoing discussions. Obviously, we still have a lot of work to do, but I agree with Dr. Santiago that I think the partnerships are great, and there's just a lot of interest with all of us for making the entire system better, particularly in Montgomery County.
Thank you, Ms. Cho. I think everyone will join me in thanking all of our presenters for doing such an eloquent job at outlining the systematic equity issues that are currently facing our community. So thank you all for your participation. It is now time to move on to our questions session. The questions will be read and presented by the speakers and our Q&A manager, Amelia Burst. I would like to introduce you to Amelia Burst.
Thank you, Leah. And thank you to all of our presenters for those presentations. They were great. And before we begin the question and answer part of the program, I just want to remind you that if you want to ask a question, you can click on the Q&A button at the bottom of your screen, type in your question, and then hit return or enter. And we will try to get to as many questions as we have time for. The program is, again, scheduled to end at 8:30. Our first question, I actually want to use one that Bernice had answered in the chat, but it's a really good question. And I think it's one that probably a lot of people are expecting, which is, aren't there still times where we can expect to need police to respond to individuals that are being violent or possibly causing an immediate public threat, who are also undergoing a mental health crisis?
Was that for one of us in particular, or just?
Well, I guess anyone who wants to start the answer can go ahead.
Well, I would just comment, I think Dr. Santiago also touched on it in his presentation, and that there's going to be kind of a continuum, that there will still be mobile treatment teams that include police when needed, and it won't just be the therapist and peer option, but there'll be all those options so that we can, meet the needs of any particular situation.
Yeah, that's a good answer. The cahoots in the cahoots model, I understand that they have been able over the 30 years to respond to 17% of all the calls that come through 911. Though that 17% represents more the behavioral health responses, and that's a significant number. I mean, when we're talking about 60,000 calls or more a year, 17% is not inconsequential, especially if those are the behavioral health response. Of course, the police intervenes in many other types of situations. But what we want to do is minimize, continue to train the therapists, the peer support specialists, so that they can respond to behavioral health related crises.
Just to add to what I mentioned in the chat, I mean, essentially, our work in the task force is really to work on the additional steps that can be taken before a law enforcement officer arrives on the scene, because the status quo has been 911 call, police respond. And we worked very diligently to look at the CAHOOTS model as one of the models to change the way we're looking at police responses to mental health crisis. So we're not saying no police show for mental health crisis. I mean, there's definitely opportunity. There's definitely going to be some times where you're going to need police response. But what steps can be taken? A couple more steps taken before it is necessary to bring the law enforcement.
Great, thank you. Our next question. I think it's probably good to do a little bit of simple definition here. And one of the questions is, what is considered a crisis? Who determines a crisis? Is a family domestic violence incident, for example, considered a crisis? Or what determines a behavioral health crisis specifically? To the average person, how can they discern what that looks like and when it's worth calling an emergency response of some kind?
That's a good, very, very good question. I mentioned just to begin with that there are behavioral health or mental health types of crises. There are also substance use related crises. And sometimes they're both, they're comorbidities. Now, what are we talking about if it's more mental health oriented? Well, someone who has some kind of psychosis or schizophrenia may have not taken their medications for a few days or weeks, and they go into a crisis, and they need supports. So that would be an example of a situation where someone with behavioral health training, a therapist, and perhaps a peer support specialist, all can respond to that kind of situation. On the other side, on the substance use, it could be an overdose, and we have many different kinds of overdoses. We have overdoses due to fentanyl, which unfortunately has become more common in recent years. It could be to heroin, it could be even to alcohol as well. So there's even more different types of drugs that you can overdose on. Now, with respect to domestic violence situations, if there's a situation where members are acting out, that's members of a family or whatever kind of situation it may be, it could require it may require a behavioral health specialist who is especially well trained in de-escalation kinds of techniques. That's part of their training. In fact, we have therapists at the Crisis Center who offer to do trainings to community groups on de-escalation procedures. So the Crisis Center team might be deployed. Remember, we're talking about creating a protocol that everyone understands, fire and rescue, the police department, but hopefully community groups as well will understand what that protocol for calling a mobile crisis and outreach team is. When we all have a common language, a common understanding, then we will know who can be deployed in these different kinds of situations.
I would also just add as a resource for people in the community that there's training called mental health first aid training. It is also very useful for the layperson. And you just Google mental health first aid and you can see a list of all available trainings locally Cornerstone Montgomery, Every Mind. We do these trainings on a regular basis and they're available. So just a resource for people so they can learn about what to do in a behavioral health crisis. It's kind of like CPR for mental health. So it's a great resource that people might want to explore.
Great, thank you. Our next question. The substance abuse team has been successful in responding to overdoses, but they can face challenges with getting people to enter treatment. So do you have any thoughts on how to get more people into treatment for substance abuse and or mental health issues? I guess this would come into the follow-up part of the crisis intervention process?
Yes, I would say that that's what the Stabilization Center is for, that we hope to deploy soon. It's a resource that is very needed right now as an alternative to jails or to an emergency room. And that Stabilization Center is not only going to be equipped with medical personnel or behavioral health therapists, but also social workers that are well trained in counseling techniques, case management, and be able to work with the individual if that individual is not certain on the types of opportunities, service opportunities available. They are well equipped to suggest a variety of alternatives, and that's what I mentioned, that we also want to deploy or hire navigators who are experts at knowing what are the resources in the community. And hopefully something will resonate with the person. If the person is still refusing services, oftentimes is because we're just not providing the wide array, the richness of the services that are available in this county. And that's why I think the navigator role will be an important one.
Thank you very much. Our next question, how will implementation of the CAHOOTS and or Crisis Now models be assessed in terms of their effectiveness and their efficiency if those models are adopted, as recommended by groups in the county?
Thank you for that question. That's a very, very important one. Right now, I can say that we don't have the funds yet from these from a couple of SAMHSA grants that we are trying to go for. That's going to be one of the steps that we can take in terms of expanding the comprehensiveness of evaluating how effective we are. Having said that, let me say that we already do significant data collection. We already have statistics on, of course, the number of people that are in crisis, but we even dig deeper. Not only do we respond to people in the community at large, but also with the schools. Pre-pandemic, we were responding to over 2,000 calls from schools in the Montgomery County public school system. And we do have statistics on also the effectiveness of the outreach. But there's always more that we can do to ensure that we're being effective as well. I welcome other members of this panel to respond as well from their perspectives.
Yeah, I would just add, I mean, one of the recommendations that I mentioned earlier in the evening was having someone or agency devoted to not just oversee the ecosystem, the collective efforts to deal with mental health crisis, but to evaluate it. I can't tell you the number of conversations we had in our task force group over those 4 or 5 months where we are constantly asking ourselves, okay, if we have this program, is it going to work? And we need to make sure it works. And we need to hold ourselves accountable to these programs actually being effective in our county, to make sure that we're actually putting these resources out there effectively. So yeah, I mean, I totally agree that there needs to be room for assessment, and the sooner we get that funding for that, the better.
Great, thank you. So kind of following along on that same note, how much of the task force's recommendations were expected to be funded by the county or the state, or possibly federal sources?
Well, regarding the task force recommendations, it's a good question. And, a lot of the members kind of felt like, well, we're just the community members, we're just giving ideas. So in terms of how it's funded, we kind of said, well, let's rely on county council and county executive to work that out. I mean, we definitely had those conversations, and, given the time frame that we had, which was about, 4 to 5 months to go over, as I mentioned, up to 87 recommendations were the result of our work. I think we had more time, we probably have delved into more discussion as to how things are funded. But really our goal was to just provide the ideas, and how it's funded. We will, I say we, collectively as a task force, because we still talk about it, we want to hold the county executive and the rest of the county accountable to making this happen. And that includes, future inquiries as to how things are going to be funded in the future. So, just because we finished in February, trust me, there's many members in task force that are ready and willing to hold us accountable and make sure that these plans actually are being put into place, and where we're going to find the money to get it done.
Great, thank you. Our next question. It was mentioned a little bit, training for 911 call centers. Wanted to ask if someone right now were to call 911 and ask for a behavioral response, are the call center operators prepared to connect them to a crisis center or a mobile team? And going forward, what is the sort of training that will be needed for 911 operators to better connect people in crisis to more appropriate non-police responders?
Perhaps I can take that question. Probably the best person. There's an emergency communications center that runs the 911 system. I've visited this location. It's run by the police department. They would be in the best position to answer this question, but I've had enough interactions with them to know that they use a national standardized protocol that it does include already the behavioral health responses and how to do the dispatch. And with that goes a lot of training of the dispatchers on how to recognize a call that is behavioral health oriented. The answer is that there's already considerable training, and I think that's probably the appropriate answer. Having said that, what we're after as we ramp up the services at the crisis center and the mobile crisis and outreach teams from just one 24/7 to possibly 6 or 8 ones, there's just going to be more alternatives. And what that means is that we may, that the practice perhaps in the past was knowing, the dispatchers know there were limits to what the crisis, mobile crisis and outreach teams were able to do. Now, with more, we will need to be in conversation, and we need to have that protocol that clarifies fully all of the responses that the mobile crisis and outreach teams will be able to do, including responses to behavioral health crisis without a police present. So that in addition to the training they already have, there will be additional training. Some of it will be done through the CAHOOTS training that we expect to do in the next few weeks.
Great, thank you very much. This next question is kind of open to anyone on the panel to, offer their perspective on. Could you discuss perhaps how this topic of crisis intervention intersects with the possibility for racial bias in policing practices? Is it possible, do any of you foresee that policing with or possible racial bias in policing could change if the approach to crisis intervention changes as well in the county?
Well, I certainly think that training and offering alternatives can have an impact. We're talking about this ourselves at Cornerstone Montgomery and how we approach treatment and therapy. We have a lot of people who speak many different languages on our, who we serve. And so, whether it's, a language issue, racial bias, I mean, we're having those conversations, as I'm sure many people are. And that's how you make changes, is having those conversations, making changes to policies and protocols, including it in your training. And I think that's at least the first step that I know a lot of people, including the police department and fire and rescue, are talking about.
Go ahead. About to speak, Dr. Santiago. Go ahead.
Yeah, it's really critical that we also engage with the communities themselves as we build these models, that we're in conversation with them, with faith-based groups, but also with our racial and ethnic groups and immigrant groups, that they feel participant in the development of the crisis now model. And even beyond race, ethnicity, nationality, there's also, I've become fully aware that we have groups like those on who experience, who are part of the autism spectrum. We also need to be sensitive to that population as well, and to recognize how best to respond to individuals in that community as well. So there are many challenges, but there's many opportunities to ensure that the Crisis Now model is also culturally competent and also appropriate for the diverse populations that we have in this county.
And just to add to that, both of them made very excellent points. And I want to kind of give a perspective of me as a member of the task force. We definitely had a great deal of conversations on this issue, right? And I want to make sure I'm hearing the question clearly. Will these all responses to mental health deal with eradicating or addressing or attacking racial bias? That was a hard question for us to simply answer. We had some folks that said training was sufficient. We had some folks saying, no, it's not. So you see in my presentation, I wrote at a minimum training, because really was like the compromise in our conversations, because there's so much into the conversation about racism in law enforcement, racism, it's just so loaded. It's hard to say that mental health is going to be the sole response, but it definitely picks away at it, because if we have a program, I kind of mentioned this earlier in my recommendation that I listed out earlier in the night, we had a preferred criteria for Crisis Now, and that included culture, competency, compassion, and very much tuned to the fact that we are a diverse community. And if this is going to work, we have to be constant of making sure that people are involved in these programs have an understanding of the cultural differences. And that goes to the need for peer workers, making sure that the individuals involved really understand the people that are in crisis. I don't know the stats off the top of my head in terms of the racial makeup of the ones that call for mental health services, but, you know, whenever that is readily available, I'm sure there'll be maybe further conversations as to, you know, how mental health responses can deal with that. I think that's very important. We got to know the population that we're working with in order to actually say, you know, are these responses to mental health really attacking racial bias?
Language is also extremely important, and we have a resource here in the county that has been building over many, many years, which is the interpretation services. Not just for, we sometimes think it's only Spanish speakers, but we also have Chinese and Vietnamese and other languages. We have a depth with respect to that resource. And those are available to us, even available to the mobile crisis and outreach teams if they encounter a situation where they're dealing with a language, with someone using a language that is not familiar to the responders. So we expect that is also a wonderful resource that we have here in Montgomery County.
Yeah, let me just add briefly, because I know we definitely touched on that quite a bit in our task force work, that we even went as far as to look at the statistics as to the number of languages that have been utilized under that language service system. And we even actually had a recommendation to make sure that we kind of audited the effectiveness of that, because again, it goes to the need to have diverse responses. I mean, it is a language program where it's not an individual speaking the language, but as mentioned, it's a service where the words are being translated. Is that sufficient? That's something we really wanted to have assessed. Because if not, then if it's a matter of just hiring people from these communities that speak Amharic, that speak Spanish, that speak Chinese and other languages, then we need to do that. But the languages program that we have in the system seems to be working, but we don't have anything in place to ensure its effectiveness. So that's one of the recommendations that we put out in the task force that I didn't address in my presentation, but that was one of the recommendations that we put forth.
I can tell you as a provider, that's a big deal. We were able to spend some money a few years ago from a grant to purchase some amazing translation software. And we have immediate access to over 300 languages, and there's like another 800 that we can schedule. If it's a rare language and they have to find somebody to do the translation, and they have all been trained in, you know, medical behavioral health terminology, and it's been a great resource that we have, because it really makes a difference.
Great, thank you. Our next question, even if these plans and proposals like the Crisis Now model or the Cahoots model were approved and implemented, would the county be able to meet the demand for the needs of, you know, people who would be using them, or would the system possibly become overwhelmed too quickly? Carrie, I think you had mentioned that there is already a kind of a shortage of beds in the county to divert people in crisis out of jails and instead into healthcare or more stabilizing facilities. So do you see, what is the sort of sustainability of the Crisis Now or Cahoots models given the demand for them in the county at this moment?
Well, I think that's part of the conversation that needs to be continued, is how do we make sure that there is the capacity to have that crisis follow-up? You know, and sometimes there's capacity, but there's other barriers like insurance or authorizations or things like that. So I think we need to keep having those conversations and identify the gaps, identify the barriers, and figure out, you know, how we can, you know, move resources around or create other ways of filling those gaps and implementing different things. Because it's none of this is going to work if we don't have places to send people, because, you know, they can't stay in a crisis bed forever. We need to know that they can be referred to other, community providers, or go home and have the support they need to be successful at home and things like that. And we are very lucky in this county. We have a lot of resources that other counties don't. So I'm very hopeful that we can keep figuring that out and keep working together to keep developing that continuum of care.
There was a study that was done a year ago by a group from Arizona. We call it the RI International Report, that indicated for the population of 1 million that we have in Montgomery County, that we will need, at least with respect to mobile crisis and outreach teams, that we would need eight of them to be able to respond to the demand of behavioral health crises. But I think the question is broader, as Carrie well answered, that in addition to that, that's a very specific intervention that occurs at the time that someone presents in a crisis. But we currently have, I mentioned this, the gap that we don't have a stabilization center, a short-term, 24, 23-hour, 1 day, 2 days, 3 day type of stabilization center. We need that. What's the alternative? Current alternative? Emergency room. And for some people, it's jail. And so we're looking forward to meet that gap. Carrie referred also, residential beds. We need more resources to open up more beds to keep people within the county, not having to go out of state. Oftentimes that's the only alternative for some individuals. So there's definitely some continue to be gaps, resources. We need support from the entire community, from the state, from the federal government. There should be increasing resources coming. Some of them are funded through these beds, through Medicaid, as Gary kind of implied, that insurance is going to be very important. But what about those who have no insurance whatsoever? We need resources to be able to fill the gaps.
Great, thank you. I think we have time for about one more question. So if a community organization or a neighborhood association possibly wanted to get some training for themselves to be able to help in either the initial response to a mental health crisis, or in fact for following up with individuals that have had a crisis, what would you recommend that organization do? Where could they look to get training, or what is the role that community organizations, however small, however grassroots they are, could play in the sort of holistic response to mental health crisis?
Well, I think we already mentioned mental health first aid can be an option. And then I know Dr. Santiago also mentioned the crisis center is available to do maybe, brief or mental health first aid is, well, you can now do it online. As well as until there's in-person options again. But that is definitely for lay people, for anyone in the community. We've done it for, individuals come, neighborhood associations can come, corporations, businesses. We've trained, different companies as well as individuals. And you can find mental health first aid. Just Google it and get the information, or you can go to Cornerstone Montgomery's website and we have a link there as well. And then I know Dr. Santiago can speak to the resources that the Crisis Center can offer as well.
Yeah, I mentioned the CAHOOTS training that should be coming soon, and I placed a call for organizations. If you are interested in de-escalation and community engagement training, they will provide it. We just need to get the list. I'm going to go out on the limb and mention what my email address is. If you have a list of individuals in your organization, send them to me or to my colleague, who I think is on this call as well, Dornay Hill. And my email is rolando.santiago@montgomerykountymd.gov. And Dornay Hill, I hope she doesn't mind. I don't think so. Dornay.hill@montgomerykountymd.gov. We're looking for lists of members within organizations that would like to have that training in the near future.
Great. Thank you. I think I'm going to turn it back over to Leah to close this out for this evening.
Well, I think that everyone should join me in thanking all of our presenters and definitely thanking the League of Women Voter volunteers, Amelia Burst, and all of the other staff and volunteers that made this evening possible. So thank you all for that. I also want to take a moment to thank all who attended. And if you have any remaining questions or anything, please feel free to reach out. If you enjoyed this program, please consider supporting or joining our work. And we'd like to invite you to visit our webpage, www.LWVMOCOMD.org. So that's LWVMOCOMD.org, where you can find links to join or donate. We wish you all a good evening and hope that we will see you at our other events. So thank you all. Have a good night.
Good night. Thank you, everybody.